jaundice in pregnancy. Okay, there are very few common conditions which cause jaundice in pregnancy, and we should know both pregnancy specific causes of jaundice and general causes of jaundice in pregnancy. So the specific causes are obstetric cholestasis, acute fatty liver of pregnancy, and HELP syndrome. These are the three more common causes of jaundice in pregnancy. Initial drug-induced liver injury is seen both in general population as well as in the pregnancy hepatitis E as well. Okay, so the pregnancy specific causes are three: obstetric cholestasis, acute fatty liver of pregnancy, HELP syndrome, drug-induced liver injury, and hepatitis E. Now, coming to the obstetric cholestasis, it is seen in 30 to 36 weeks, usually present with itching over the palm. So it's usually seen in third trimester of pregnancy where they present with jaundice, usually associated with the urinary tract infection. Here, the patient with present with high bilirubin in about only 10% of the patients. The patient may have slight increase in bilirubin or mild elevation in the liver enzymes, especially alkaline phosphatase and GGT. Remember that alkaline phosphatase is also secreted by the placenta, so it may not be very helpful in pregnancy to diagnose any cholestatic liver disease. Acute fatty liver pregnancy again present in the same trimester, third trimester. Here it's a severe disease compared to obstetric cholestasis. Here the patient will go for acute fulminant hepatitis and present with hepatic failure. So we know the function of the liver is to synthesize coagulation factors and detoxify the blood. So because of the acute liver injury, the patient will have coagulopathy because of lack of synthesis of coagulation factors. Patient also has encephalopathy because of lack of detoxification of the food and the drugs. So defective, the basic pathology here is lies in the fetus, not in the mother. Okay, remember here acute fatty liver pregnancy, it's the fetus which is abnormal. It cannot what called as it cannot uh, oxidize fatty acids. So because it cannot oxidize fatty acids, the fatty acids within the fetal blood will enter the maternal blood, and the maternal blood will transfer all these free fatty acids into the liver. So the liver will undergo acute fatty change and go for liver failure. So this is the mechanism of acute fatty liver of pregnancy. There are certain risk factors which are important when you're going to diagnose this condition, because the epidemiological clues in the question scenario will help you to diagnose this condition. Acute fatty liver of pregnancy is more common in old maternal age, parity, multiple pregnancy, and preeclampsia. Symptoms of acute fatty liver of pregnancy are nausea, vomiting, abdominal pain, itching, polyuria, polydipsia, and encephalopathy. Treatment includes termination of pregnancy is the main treatment here. Now, because when you're going to terminate pregnancy, the fetus and its metabolic products are out of the maternal blood, that will automatically decrease the free fatty acid level in the maternal blood and will lead to recovery of the patient. So remember, acute fatty liver pregnancy, the clinical scenario in MRCP exam will be a third trimester mother who's rapidly deteriorating, has some bleeding manifestation and altered sensorium, and our patient usually improves after termination of pregnancy. Okay, the treatment of choice is termination of pregnancy. It's more common in twins, so you might multiple pregnant more common in twins, so that could be additional clue in the exam. Moving on to HELP syndrome. HELP syndrome stand for hemolysis, elevated liver enzyme, and low platelet count. It's a severe manifestation of preeclampsia. Preeclampsia is a condition where you have hypertension in pregnancy, which begins after 20th week of gestation. Now, a severe preeclampsia can lead to HELP syndrome. Here, the patient may present with nausea, vomiting, epigastric or right upper quadrant pain, headache, visual changes, jaundice. Okay, and there could be other features which are consistent with severe preeclampsia. Now, workup may show a complete blood count, which may show thrombocytopenia, anemia, or cystocytes. That could be elevation in the blood urea and creatinine. Patient may have acute kidney injury. The liver function test will predominantly see a very high level of AST and ALT. There could be increased LDH because of hemolysis. Other causes of acute abdomen, such as pancreatitis, should be suspected, and amylase lipase will turn out to be normal. Okay, so the clue here is again a patient who is already has a preeclampsia and is having worsening blood pressure control, has a recent onset of abdominal symptom like nausea, vomiting, abdominal pain, has headache. Okay, so this indicates a severe preeclampsia. And when you investigate, you will find that the patient is having anemia, which is hemolytic in nature. You have thrombocytopenia and mild acute renal failure. Okay, so these are the clues that patient is having HELP syndrome. Moving on to the metabolic disease of the liver, which frequently comes up in the exam, it's Wilson's disease. Wilson's disease is an autosomal recessive disorder. Autosomal recessive means usually there is a skipping of the generation in the family. That means there could be one of the generation may not have the disease, and usually 25% of the siblings are affected in a given family. So Wilson's disease is because of the defect in a transporter known as ATP7B gene, which codes for a copper transporter. This gene is located in the chromosome 13. Because copper, which is accumulated in the liver, cannot be secreted into the bile, it gets accumulated within the liver cell or hepatocyte. So that copper accumulation within the hepatocyte will lead to hepatocyte degeneration and loss. So Wilson disease can present in two age group, that is a young patient who's less than maybe 5 years, and another is adolescent who is like about 15 to 20 years. The presentation is different for the two age group. In children, usually present with chronic liver disease, whereas in adolescent, it usually present with neurological disease. Uh, uh, Liver disease could manifest with hepatitis, that is mild elevation in the liver enzyme, or they can present with chronic liver disease with ascites, fetal edema, and anemia. CNS disturbance is more common in adolescent patient, where the patient can come with speech and behavioral problems. Often the first manifestation that could be tremor or chorea as well. You can also notice some KF rings, Kaiser-Fleischer rings. Uh, the RTA could be another rare manifestation of Wilson's disease. RTA stands for renal tubular acidosis. Now, the same copper which is accumulated in the liver can also get excreted in the urine and can get deposited in the renal tubular cell, especially the proximal tubule, because proximal tubule is the one which comes in contact with the urine in the initial part of the nephron. So the damage to the proximal tubule is much more higher, thereby resulting in what's called Fanconi syndrome. Fanconi syndrome is a group of a collection of symptoms where the proximal tubule is defective, which leads to loss of calcium, phosphorus, amino acids in the urine, along with the acidosis, because proximal tubule is the site of absorption of bicarbonate. Now, this KF ring is very important in MRCP exam, because KF ring indicates that patient, about 90% of these patients have neurological manifestations of Wilson's disease. Okay, so KF ring is quite specific for neurological manifestation of Wilson's disease. Liver involvement is seen usually in 40 to 60% of the patient who have got KF ring. This KF ring is classically distributed in the periphery of the cornea. Here, the copper deposition is in the layer of the cornea known as Dismets membrane. These patients who have got very high copper level in the blood can have hemolysis, they can have blue nails. So diagnostic test for Wilson could be decrease in serum ceruloplasmin. Ceruloplasmin is a protein which carries the copper. Now, because copper is in excess, the ceruloplasmin, whatever in the blood, is already bound to copper. So the free ceruloplasmin level will be decreased. Now, because copper is high in the blood, it will be excreted in the urine. So if you measure the 24-hour urinary copper excretion, it will be very high. In addition, there could be increase in the uric acid level, which is a corroborative evidence, because uric acid is not absorbed again because of tubular injury. Management, you need to, the goal of the treatment is to reduce the copper level within the blood first, and subsequently within the hepatocyte. So you need to use some chelating drugs. So D-penicillamine is one of the drugs which is used to treat Wilson disease, where which is given in a dose of 1.5 to 2 grams per day in divided doses, then about 0.75 to 1.5 gram per day in maintenance. You should can also it can also be given in associate can be given with zinc or trientine. So zinc and trientine is more preferred with the patient has neurological involvement. So this is a slide which summarizes Wilson's disease. The defect is in the chromosome 13, the ATP7B gene. You not remember these names for MRCP exam, but do remember the manifestation. So copper level is much higher, which will lead to KF rings. You have very high urinary copper level, so 24-hour copper level will be clue. Ceruloplasmin level will be low. The free copper level in the blood will be high. The patient with neurological Wilson disease will usually manifest with a young Parkinson-like or motor symptoms. For example, they come with a tremor. So if you see a young onset Parkinson disease is typically seen in 50s and 60s. But if you see a very young patient with Parkinson's disease or extrapyramidal symptom, you should always rule out Wilson's disease as an etiology. If you do an MRI, you might find copper gets deposited in the right nucleus. So you will find what's called face of the panda. That's an MRI image finding